So I'm actually grateful for that little interruption because all of you are awake now. Because being the last speaker, that's something we always have to fight with, right? Now, as I said in the beginning, I have several tasks here. As the last speaker, I think I should extend all our thanks to the organizers, to Giovanni Gambaro and Emiliano Crappi, who have put together a wonderful meeting here, very high scientific standard, but most importantly, and that will come out in my talk, they have put a seed in all our brains that there is this other specialty which is not competing, which we probably should work together with, and we can learn a lot of each other. So I think we should give a big applause to the two, Giovanni and Emilio. Good. I will tell you why we should work together. No, really, Giovanni, this should have been the first talk, not the last talk. Because by now you should actually know why we should work together. But anyway, what I will attempt is to bring you back from souls and molecules, and then Kemal has already made a step and brought you back to the stones, and I will bring you back to the global or bigger picture of the whole thing. Now, as you all know, nephrologists and urologists kind of live in a different world, and they talk a different language, right? We can all talk nicely to each other over dinner, but really, we say the same thing, we may mean a different thing, right? Some examples. Yesterday, it struck me that one lady here said, the kidney function then over the years was deteriorating and the creatinine was going from 1.1 to 1.2. And I was thinking the average urologist wouldn't have even noticed that the creatinine was going up like that, right? So the typical creatinine case for urologists is we get a single kidney with a stone and the creatinine is 450. We deal with the stone and we keep the patient for 1 day, the creatinine comes down to 350. We say, okay, it's on the way down, go home. That's it, finish. So that would be the typical approach of a urologist. The other thing is that I heard nephrologists talking about large stones. And then they showed a picture of a 1 centimeter or 8 millimeter stone, which for us urologists are really small stones. So for a urologist, a large stone is 5 centimeters, or at least 3 plus. So we do speak different languages. We use the same word, but we have probably different meanings. So we need to kind of address that. I want to tell you a little joke. There's a group of doctors sitting in a boat, and they are hunting ducks. And the first duck flies up, and the nephrologist takes a gun and aims, but he doesn't shoot because he thinks, is that a duck? Or is it maybe a goose? Or is it a mixture of both? So the next duck comes up, and the surgeon takes the gun, and boom, the duck comes down, and he turns around. There's a pathologist there, and he says, go over there, and let's look if it was a duck. All right, so that's the difference in thinking. Good. How do I bring this forward? Next. So the world of stones has changed. It has really changed. And if we only look at 1 decade, from 2000 to 2010, these are UK data, there's a 63% increase in upper tract stones in hospital episodes. There's a 55% increase in ESWL treatments, thereof 70% for renal stones. And as we just heard, there is a 127% increase in URS treatments. Now, if we look at the stone composition, these are Portuguese data from José Rey Santos, then the uric acid composition decreased from 19 to 9%, and so did the infection stones from 15% to 4%. So clearly, and we all know that, there is a significant increase in calcium oxalate stones. Now, people these days have a longer lifespan, they live in affluence, and they have an unhealthy diet, no doubt about that. And that creates an epidemic of overweight, obesity, and diabetes, known as a metabolic syndrome, or more popular as diabesity. Now comes to it that the lifespan on average has increased in Western countries to 25 years, so people have longer time to eat, longer time to grow fat, and longer time to develop diseases like the metabolic syndrome. And this is not only true to the West, because the developing countries are getting these days the blessings of our Western diet. So they do get the blessings of metabolic syndrome and associated diseases. Now, Italy is not only the country of the Colosseum, of good food, nice weather, but it's also one of the leaders, actually the third place in Europe, of diabesity. You may not see, I was actually looking around in Rome, and you might not see it maybe in the urban setting. I guess that is more true for the rural setting, right? Now, if you look at the lower picture, for the United Kingdom, there's a prevalence of obesity of almost a quarter, meaning that every fourth person is overweight or obese. So this is a big, big number. Now, if you look at the upper picture, this is the relative risk of stone formation as compared to the weight. And of course, it starts only at 150 kilograms. Now, this is already something, right? And to reach the right side with 220 kilograms, you have to eat a lot of spaghetti. But nevertheless, it clearly shows there is a correlation between overweight, an increase of overweight, and the risk of stone formation. Now, these are women with heart conditions, so myocardial infarction, angina, and chronic heart failure. And you can see the red bars, they show clearly an increased incidence of stone formation as opposed to women who don't have these heart conditions. And if we look at hypertension, you see there's a significant rise of the red bar on the right side, and those are hypertensive women. They have clearly more stones. Now, we have talked yesterday about the solution, and this will come more and more and more. It's the gastric band. Now, we would agree that bariatric surgery is the only intervention that facilitates significant weight loss in the morbidly obese. We all agree to that, right? It does result in sustained weight loss. It improves diabetes. It improves insulin resistance. It improves sleep apnea. It improves hypertension. And it improves your cardiovascular risk factors. No doubt about that. But there's a downside to it: osteoporosis and osteomalacia. So that leads then to hyperoxaluria, nephrolithiasis, and nephropathy. So we may see after a diabesity what I call the age of calculosity, which follows the age of diabesity, just like the Roman emperors, one after another. So we might see an increased prevalence in uric acid stones due to the low urine pH, and we have heard about all that. And we might see an increase in calcium oxalate stones due to hyperoxaluria. Now, I'm just picking a few aspects here to paint the global picture. So we do know that diet and lifestyle do influence the stones, and we have heard about single aspects here. The low intake of fiber, calcium fluid, a high intake of animal protein, refined sugars, oxalate-rich food lead to hypercalciuria, hyperoxaluria, hypositraturia, and low urinary volume. We have heard single aspects of this. We have heard dietary recommendations. So this is well established. So how it works is that obesity leads to metabolic syndrome, and that leads on one hand to cardiovascular diseases, it leads to urolithiasis, and it leads to other associated conditions. Now, why I'm putting this up? Because, as Kemal rightly said, and you have already, given half of my talk in the beginning, by the way, stone disease can no longer be seen as an isolated disease, right? So it is part of a bigger picture, socioeconomic as well as health picture. Now, when patients ask me, "Doctor, why do people form kidney stones?" I usually say, if I knew that, I had the Nobel Prize. It's about 20 different factors that play a role. And it has to do with our environment. Now, environment is defined as affecting the existence, growth, and welfare of all beings, or if we talk about our internal environment, of the being, which is us. Now, the external environment, we all know that, is diet, climate, and global warming. The occupation, we heard today about the steel workers. The surgeons, I was surprised that the surgeons should take some citrate before they go into the OR. The lifestyle, and of course, toxic exposures. And you see here drugs, you see toxics, and you see food as well. Now, you all know that Paracelsus already in the 14th century said everything is a poison, it's just depending on the dosage, right? We had a case in Germany at Eastern, he ate 25 eggs and he died, right? So eggs can be poison. Anyway, our internal environment, age, gender, genetic factors, metabolic factors, effects of other organs on the kidney anatomy, papillary lesions like Randall plugs and systematic impacts on the kidney. Now, all these factors, they either lead to changes in urinary composition or they lead to changes in the kidney itself. Now, I've been in the stone business for about 30 years now. And whereas on a molecular level we are moving forward, we are really stagnating finding a solution. And that is probably because we gain a lot of knowledge, but we are far from applying our wisdom. Now let's take as an example the calcium stone former. Now, in the mechanistic thinking of a simple urologist, an idiopathic calcium stone former is a patient who has a stone and we don't know why. Full stop. That's a simple mechanistic thinking of the average urologist. Now, for the nephrologist, there's much more behind it, as we all have heard for the last 3 days. How do we investigate this guy? How do we advise on prevention and treatment? How do we make a proper diagnosis? And do we get a proper stone analysis? So all these questions have been addressed in the last days. So we all know that the idiopathic calcium nephrolithiasis means a stone known or be suspected of calcium oxalate with a minimal part of hydroxyapatite being allowed in that definition. Now, why is that relevant? Because a proper idiopathic stone former, as I said before, has no reason to form stones in apostrophes, and that means we have to give him generic, or as it was put earlier by, said earlier, empiric treatment by David. The other thing is it's important that we all get the right definition, because if we define the idiopathic calcium stone former differently in urology and in nephrology, for example, how can we compare our data? How can we compare the studies? We cannot. So it's important to get the definitions right. And of course, it's important to differentiate of other calcium oxalate stone formers that may need different investigations. Now, as I said before, the mechanistic thinking of the urologist says an idiopathic calcium stone former is a stone without a reason. Now, for the nephrologist, immediately this kind of table comes up. So for the nephrologist, there are about 20 reasons, at least, to investigate. And I'm just taking this to show you how we speak a different language. And maybe we need to work on this language. And even if the urologist does a 24-hour urine analysis, we usually find things like hypercalciuria, hypocitrate and hyperoxaluria. Now, if we dare to treat these patients as urologists, we will probably treat them symptomatically. So if you have low citrate, give citrate. If you have high oxalate, avoid oxalate. If you have a high calcium, get the calcium down. But that's as far as we go, right? So that's where we need the help of the nephrologist, because as you can see on the left side, there's a whole array of diagnoses that needs to be considered. So stone disease has become much too complicated for one alone. And I invite you to guess who in this picture is the nephrologist and who is the surgeon. So it's clear that it cries out for a multi-specialty and multimodality approach. But what is the reality? Now, this is a nice definition, the annoying time in between sleep and internet. We tried to find out what the reality is 2 years ago, and we did a little survey, and I have just here a short version of the results to remind you of that survey. So we sent 523 surveys out, and the response rate was kind of a bit weak, 14.5%, but nevertheless 76% of urologists and nephrologists responded. I think, Manuel, are you here? It was urologists only, no? Or not? Both, yeah. So the overwhelming majority of the responders worked in major tertiary hospitals. And they were all well experienced with many years of clinical practice under their belt. Now, when we asked the urologist, do you have access to a nephrologist service? Not surprisingly, 90% would say yes. They would have a nephrologist somewhere in their hospital, right? But when we asked them, are your nephrologists interested in stone disease, 52% said clearly no, right? So that's more than half. And not surprisingly, only in 20% of those who had access to the nephrology service, there was a kind of stone clinic going on. Now, we didn't go deeper into that because a stone clinic can be from very sophisticated to very basic, so we don't know that. It also turned out that the responders, which we assume, rightly or wrongly, to be interested in the stone disease, were not necessarily from high-volume stone centers. Now, then we ask, how often did you refer patients to the nephrologist? 40% said never. So they meet their nephrologist only in the cafeteria for lunch. That's it. Occasionally 50%, that's maybe a little bit of light at the end of the tunnel. How many patients have you referred in the last 4 weeks? 30%, none. 42%, 1 to 5%. So again, a little bit of light at the end of the tunnel. Now, if we look at the reasons why they refer to the nephrologist, then you can see the red numbers here, that whatever has to do with stone and stone prophylaxis and metaphylaxis is number 2 in the referral scale. So stone disease is nevertheless very important for the cooperation between urologists and nephrologists, and that is acknowledged. Now, these are a few tables which just illustrate, and you don't have to read them, just illustrate certain conditions that have a high risk of metabolic bone disease, a high risk of chronic kidney disease, or even a very high risk of chronic kidney disease, and a high risk of recurrent stone formation. Now, these are all patients that the urologist will see at some time and may want to refer to the nephrologist, or the nephrologist will see, and because there is a stone bugging the patient, must refer to the urologist. So you see the difference, right? The may and the must. So we need, in a nutshell, we need to change the thinking, right? We need to change the thinking. We need to think cooperation, not individuality. And this is the short overview I wanted to give you. Thank you very much so far.